So much, Madam. I now request Madam Dr. Unmana Visaikia to kindly accomplish our distinguished dignitaries to the VIP lounge. With this, we will be starting our scientific sessions.
To have with us Honorable Dr. Inu Bora Ma'am, Assistant Professor, Obstetric and Gynecological Nursing, Regional College of Nursing, Guwahati. I request Dr. Inu Bora Ma'am to kindly come forward and chair the session. Ladies and gentlemen, please welcome our esteemed panelists with a big round of applause. Respected Dr. Devajit Sharma Sir, Chief Neonatologist and Pediatrician, Satribari Christian Hospital, Guwahati.
It's me immense pleasure that today I am going to moderate the first panel discussions. So I, Dr. Inu Bora, I am from the Regional College of Nursing. I am working as an assistant professor. So I am having 24 years of experiences in the field of nursing, especially I am related with the teachings. So, and I am going to serve as a moderator in these important sessions. Today we are going to focus on one of the important topic of healthcare. So like we can say like safe childbirth is not a luxury, so it's like right of. It's a right, and it's a right for the mother, it's a right for the baby. They deserve for safe, respect and quality healthcare services, irrespective of their geographical boundaries, their incomes, their socio-economic status. So they deserve it. So childbirth, it is one of the core part of maternal and child health, and it is, we can say like it's the key goals for the universal health coverage. So as we know, despite of advanced medical facilities, still many millions of maternal deaths and newborn deaths, it's occurring. So if we say globally, we can say like your estimations of more than 3,000 maternal deaths, or 2.7 stillbirths, 2.6 your your infant death. So it's annually it is occurring or reporting. So it is actually generally we can say like these deaths are occurring in the low resource settings areas. And it can be preventable. So these deaths, how we can prevent it? By if we see from antenatal onwards, with proper antenatal checkup, with proper screening of the high-risk mother, with your skin birth attendance, then clean delivery practices, then recognitions of babies. If we find out like your emergency, like what are the emergency obstetric care it is needed during the time, if it requires, then you can say your proper your newborn care or newborn assessment and postnatal care. So with all this, if we are giving like providing the quality services during that period, we can reduce the maternal death and infant mortality rates. So if we see that universal health coverage, it plays a critical role and it ensures that everyone they access the essential health services without financial burden. It has to improve these outcome barriers like shortage of health workers, poor infrastructures, cultural challenges, financial challenges, and poor quality of care. To save more mothers and babies, we need strong health systems, they trained health workers and enough medical supplies. So now let me introduce our distinguished panelists. Each of them will bring unique expertise to today's panel discussions. So we are honored to welcome our first panelist, Dr. Devajit Kumar Sharma. Devajit Kumar Sharma, sir. So, he is going to speak on essential newborn care strategies to reduce IMR. So, we are also pleased to welcome Dr. Swati Zalan, In this discussion, she will be addressing on emergency obstetric care, identifying and management of postpartum complications. We are also pleased to have Mrs. Bhavna Verma. She will discuss on postpartum support, transforming the modern newborn care setup, and nurses leading with kangaroo mother care innovations. So, now may I request our first panelist to proceed.
Good morning, everyone. This is a very really important program on patient safety, and I am very delighted that we are asked to talk on safe childbirth and postnatal care. You know, due to medical error, daily the number of deaths across the world occurs is equal to, if we drop to big jet daily, then the number of deaths will be much more than the two medical patient died due to medical error. So patient safety is our priority. Another thing I am just saying that ANEI has already elaborated the number of days, maternal days, number of neonatal days, and also number of stillbirth occurs. All some are unavoidable, but most of them are avoidable. In India, still neonatal death is, that is first 28 days of life, is around 20 to 30 in different stages. But in most of the developed countries, it is below 5. So we have lots of things to do. For that, we don't need rocket science. We don't need hi-fi setup with our back-end ventilation and mechanical and all the facilities, all the non-NIV or whatever the facilities we don't need. Because less than 1%, not even 1%, 0.1% babies need all the facilities. What we can do is do basic thing right. Patients, if we do the basic thing right, our neonatal mortality as well as maternal mortality will come down drastically. For example, let me share. Baby's birth is a very natural phenomenon. Be it human baby or be it animal's baby. If it is natural phenomenon, if we go back to the nature, then everything will become. Because many of the death, because we are trying to influence, trying to intervene more and more. That's why more and more many deaths are because of that as well. If we going back to the nature, you see now neonatal care, before we were using incubator and ventilator, now we use hardly any ventilator. But rather than using incubator, we stretch in some kangaroo mother care, we stretch some breastfeeding, we stretch some delayed cord clamping. Before immediately baby born, cut the cord and throw the baby, but it is not there. We are going back to the nature. If we going back to the nature, many things can be done. Another thing is that we should always remember, before I go into actual topics, let me just elaborate why babies are dying. If we are going to baby matured at 40 weeks of gestation, we should not forget that baby matured at 40 weeks of gestation. Not because baby's brain cells develop until the 48 years. Baby cannot mature 37. It's a very, it is our misconception. Minimum 38 weeks, not 37 weeks. So some baby, we all know, those baby born preterm, 32 weeks, 32 weeks, we all take care, baby are admitted in ANEI, those babies so increasingly safe, we are able to say. But the grey area is baby born between 34 to 38 weeks. In those areas, our ANEI are full, we don't take care of Papa, we send them to the mother, and many babies die due to the complications of this 34 to 38 weeks. Most of the, if obstetrician says that baby needs to be operated due to some emergencies like preeclampsia, antepartum hemorrhage, these things are fine. But unfortunately, now cesarean sections are doing most of the time because mother can tolerate the baby. There is some tithi, there is Janmashtami, there is some day, and we want elective cesarean section, that is our causing harm. So this is, we are going away from the nature. Sometimes to make that fixed date to the common date between the attendant and also the obstetrician. So if obstetrician wants, because of the medical indicator, if obstetrician advice, then different thing. But we are doing many and many cesarean sections because mother wants and other social causes. So that is another thing. If we are going away from the away from the nature, that is also causing us newborn, maternal and all this increasing. If we see why newborn mortality rate is so high, if we find main causes are in India, lower weight, extreme lower weight, prematurity, infection, hypothermia, all of this can be really prevented. You see, first all baby must be attended by a trained birth attendant, not necessarily by a pediatrician, but who are trained birth attendant. That's why we are stressing and we are doing basic neonatal resuscitation program across all Assam and across all India. After doing BNHA, we are saying the program is good. The neonatal mortality rate is really drastically reduced. It was 30 about 5 years back. Now I am happy that in Assam it is reduced to 19. That PNCRP program, it was originally 2 days. First day, how you will resuscitate the baby. Second day, how you will take the baby, the postnatal care. So every birth must be attended by a trained birth attendant. We all know 90% of the baby after delivery take breath on its own, but it is a transition. In the mother's, when the child is in mother's womb, they get oxygen and everything from the placenta. But as soon as we cut the cord, baby has to take breath on its own, on blood circulation from its own heart. This transition 90% can baby do without any problem, but 10% baby needs some help, and we don't know which baby will need help. So all birth must be attended by trained birth attendant. Number 2, we should encourage more and more institutional delivery, not home delivery. In India still, especially in the northeast region, especially in the hilly districts and remote areas, many births still occurs at home. We should encourage institutional delivery, and we should encourage all baby must be delivered by a trained birth attendant. Number 2, if a birth asphyxia is one of the most common cause of the child newborn death, and if we do it, we can reduce birth asphyxia to near zero. Baby can die due to congenital malformation, but baby should not die due to birth asphyxia. Baby should not die due to neonatal infection. Low birth weight and premature delivery also can be prevented. Similarly, Dr. Popale Swati also tell how to attend delivery, like clean surfaces, clean area, clean cord clamping. Cord clamping again, when we should cut our cord, anyone? When we should cut the cord of the baby's cord. Baby's cord should be cut when pulse stops. Dr. ANEI say, anyone? We should not cut the cord before 1 minute, 1 to 3 minutes, unless baby needs some resuscitation. Okay, so delayed cord clamping, clean surface, clean area. Then when we should start breastfeeding? Where baby should be delivered? Going back to nature, I am telling, away from the artificial things, going back to the nature is the best thing. So baby should be always delivered in mother's abdomen. Be it cesarean section, be it normal delivery. We will supply cesarean section, abdomen is open. But how we can deliver the baby in the abdomen? But there is still plenty of space left in this, between the two breasts and the abdomen, upper abdomen, there is still plenty of space. So keep the baby, deliver the baby in the mother's abdomen. How it will help? It will help skin to skin contact with the mother. Baby will remain warm, so there will be less birth due to hypothermia, due to hypothermia. Breastfeeding should be initiated immediately. We can in the meantime, some birth attendant has to monitor baby's pulse rate, respiratory rate, color, and mother can also monitor. If any problem, we can easily shift the baby to the transfer area. Baby, we should immediately start breastfeeding, because baby immediately if we start feeding complete total exclusive breastfeeding, percentage will increase. Baby will get the colostrum. Colostrum is the first vaccination. If we baby get the colostrum, then what will happen? Baby will be immunized with all the good antibodies of the mother is already having, apart from media and other. But unfortunately in private hospital now, baby is crying. So people with tend to give, hospitals are tend to give some artificial feed so the baby stop crying. I tell you, crying does not mean that baby is hungry. Baby has only one language. If baby is having pain, baby is having too much light, too less light, feeling warm, feeling cold, feeling lonely, feeling bored, passing urine, passing stool, baby has only one language, cry. Cry does not mean that baby is having less milk. Only thing we should know that baby is having more milk. How we can know? 5 days. Initial 5 days, baby should pass on within 24 hours 1 urine. Next day 2 urine, 2 times urine. Day 3, baby should pass 3 urine 24 hours. Day 4, baby should pass 4 urine. And day 5 onwards, baby should pass minimum 6 urine in 24 hours. Along with that, if the baby is for 2 to 3 hours after his feed, baby gain weight. How the baby gain weight? First 5 days, baby will lose weight, but it should not be more than 10% of the part weight. And then he will regain part weight by day 10. After that, baby should gain weight, minimum 20 to 30 grams per day. So, most of the commonest cause of giving artificial milk to the baby is crying, baby is crying. Baby cry does not mean that baby is having less milk. So, another thing is that how to prevent hypothermia. Hypothermia is very unfortunate cause of death, but it happened in India. Baby either too much clot, baby become having fever, or because of too less clot. So baby should, if we keep the baby delivered in the mother's abdomen, cover with both the mother with the same cloth, chance of hypothermia will be very less. For even low birth weight and preterm babies, which are not requiring any mechanical ventilation, even if requiring oxygenation, we to start practicing kangaroo mother care. How many of you promote kangaroo mother care? Most of you are tutor, no? How many of you are working in hospitals and promote kangaroo mother care? It's good, quite number of people are hanging. But so how many of you are actually involved in neonatal care, newborn care? Few people are raising hand for neonatal care, they are raising hand that they are doing kangaroo mother care also. These are not very rocket science. They don't have to be very big scientists, big neonatologists to do. If we can do this, such simple thing can reduce neonatal mortality by leaps and bounds. Number 1, train birth attendant. Number 2, clean surfaces. Number 3, prevent hypothermia. Number 4, prevent infections. And also proper antenatal care by the Dr. Swati will have ensured by proper antenatal care, they can reduce the preterm birth, they can reduce the low birth weight, maternal care by proper nutrition to the mother, proper regular shake-up. How many shake-up and idea Dr. Swati will tell, I have not said, but regular, it should start from very early, even before conception. First starting with folic acid and mother health. Before conception, if we make the mother free from any diseases, start folic acid, then start conception in a very healthy mother, and then regular step that we can reduce the preterm delivery and also low birth weight babies by insignificant number. We can easily prevent almost all birth aspects if some birth attendant is present during the delivery. Then neonatal infection, I was saying, by a clean surface, clean area, clean cord, clean clamp, and also by hypothermia, by kangaroo mother care, delivery in the mother's abdomen. These are not a big thing. And last thing is immunization. We should start immunization the baby because of most of the cause of infant, not neonatal death, but infantile disease, another common cause is infections. We should start immunizing the baby from the birth with hepatitis B and OPV and BCG doses, and then regular immunization. Exclusive-based feeding, and you see, to reduce neonatal mortality from present 19 to 5, we don't need any very high technological award, high trained stuff. Only what we need is our weaning and going back to nature. Thank you.
Mortality ratio. The present sustained development goals target 3.1. Intervention is possible. So, regular antenatal checkup for early diagnosis of pregnancy, for hypertension, severe anemia, If suppose her hemoglobin levels is less than 11, every patient should be taking iron folic acid tablet during pregnancy. But anemic patients may increase the dose of the cause of anemia if she is more anemic. If severe anemia is assessment and associated with blood transfusion, if suppose the blood transfusion facility is not available at the hospital, it can be referred to the higher center. So that anemia is not the cause of maternal death. Right? Then, if suppose she is having placenta previa, placenta accreta, she might be having antepartum hemorrhage or she might be having postpartum hemorrhage. So these patients we can be diagnosed early if she was a regular antenatal checkup. So we can directly refer her to a tertiary center if the medical facility in that area is not in the one. So we can directly refer her to a higher center. So in this, if she is on regular antenatal checkups, we can prevent many important causes, many preventable causes of maternal death. Second part of my question was, I think, identifying and managing postpartum complications. Postpartum complications, postpartum period is, or the period is up to 6 weeks after delivery. So postpartum complications also usually happen in those mothers who are having some or the other antenatal problems, be it anemia, be it placental problems, placenta accreta, placenta previa, twin pregnancies, hypertension during pregnancy, diabetes in pregnancy. So if these patients were monitored adequately during pregnancy, usually the patients do not suffer from postpartum complications because patients are aware that she might be having these problems in the postpartum period. Even the family members take extra care of these patients. And family members also aware of the BP to BCS level during pregnancy. We should go for regular BP monitoring, at least if we cannot take her to the hospital regularly for BP monitoring. Or she should be taking her antihypertensive pills regularly because she might develop high blood pressure and then complications like eclampsia, convulsions and others. So usually those mothers who were having certain problems in the antenatal period, they are at a higher risk of developing postpartum complications. But nevertheless, even those absolutely normal mothers during the antenatal periods and childbirth may also suffer from postpartum complications. She might also suffer from postpartum hemorrhage. She might also suffer from hypertension. We have seen patients who were absolutely normal during the pregnancy. The BP never rose more than 120 by 80 millimeter mercury, even during childbirth and in the hospital. When the patient was there with us for 3-4 days, the BP was never on the higher side. But she might complain of severe headache after 1 week of delivery, and then when we checked her BP, it was 190 by 110 and something like that. So we should not ignore those warning signs of high blood pressure. Even the family must be made aware. If she complains of severe headache, don't ignore the symptoms. If she complains of visual disturbance, blurring of vision, abdominal pain, incessant vomiting, these symptoms should not be ignored. Low urine output, abnormal swelling of the body, that is anasarca. So these symptoms should not be ignored if we want a healthy mother. So as soon as the patient, the family members or the patient find these symptoms, she should be brought to the nearby medical facility. Then other complications like sepsis. Sepsis might also develop in the postpartum period. Suppose the patient has retained bits of conceptus. Sometimes the placenta bits might remain inside the uterus. Or sometimes if she has had an abortion, a medical termination of pregnancy by surgical means, there might be retained products of conceptance inside the uterus, which might become infected and later on lead to sepsis or hemorrhage. So every possible sign, abnormal sign should be looked into with utmost care. Nothing should be ignored, what I feel. That who is about bleeding to wear thake, or weakness to wear thake, no. Because it is weakness, patient is suffering and patients usually ignore the symptoms. They think that the patient has not slept overnight, the baby was crying and so she was feeling weak. Maybe she is feeling, the headache is because of that. The patient could not sleep overnight. It might be because of that, but we should not ignore the symptoms.
Sorry to interrupt.
Yeah.
Sorry, ma'am. I'll wrap up soon. I was taking you to consult it.
I will wrap up soon, ma'am. So these are the warning signs we should make the patient and the family aware, and so that we can take adequate control measures, prompt action, and we can save our mothers from abnormal or adverse circumstances. Thank you so much.
about kangaroo mother care and mother newborn care setups. And as we explore how the nurses can lead to this transformation of kangaroo mother care and ensure that kangaroo mother care is not just a practice, it's a standard to deliver care in the postnatal care. And we all are talking about neonatal and maternal health right now. So you all know kangaroo mother care is a life-saving, evidence-based practice that not only reduce mortality but also improve mom bonding and breastfeeding. And what makes today's discussion important, that it's not a topic, it's a call for action, that there is a paradigm shift in the setting of these mother newborn care setup. We are now becoming and giving more continuous, compassionate and family-centered care to the both mother and the newborn. Let's quickly start with the session. The topic is transforming the mother newborn care setup. So now, as we all know, that 20 million infants are born with low birth weight, and more than 90% of them are from lower middle income countries. We know that it accounts for 70 to 80% of all neonatal deaths. So that eventually leads to the low birth weight and the increased risk of early growth retardation and developmental delay. Next is, we know that the low birth weight care, we know what postnatal care we are giving. Like first we are giving kangaroo mother care, and we are also giving early postnatal contacts, exclusive breastfeeding, thermal and infection prevention to the newborns, and also maternal support with the family-centered care. So this is all the postnatal care we are giving in the postnatal units to the low birth weight and as well as to the mother. Next is this is the picture of the Safdarjung Hospital level 2 NICU, in which you are surprised to know the mother and newborn both are stayed together for 24/7, but also the neonate is getting the care as same as that of the that we are giving in NICU settings. So here is the one unit picture of mother newborn season and adjustable bed with adult back support. Next is the other infrastructure which includes in the mother newborn care setup is there is the examination cubicle for mothers, pantry, toileting and bathing area. And also medical rounds are taken by neonatal team and medical rounds are taken by obstetrician team for both the mother as well as to the newborn. Next is what are the nurses' experience, that how the nurses were trained. In this, we know that we are giving care to the mother, monitoring of vitals, recording temperature, heart rate and BP, immediate monitoring of pallor, bleeding per vagina and breast conditions, administration of oral and IV antibiotics and other supplements also, assisting in episiotomy care, perineal care, removal of suture and wound care. This is all about the maternal care we are giving in the postnatal wards to the mothers. Similarly, we are also giving care to the newborns. That we help in neonatal resuscitation, essential care package is given to all the sick neonates. Immediate and kangaroo mother care should be provided. Neonatal nursing care is given while the baby is in KMC position. We assist feeding, IV access, and we give monitoring to the sick newborn as well as oxygen saturation monitoring along with the provision of respiratory support. Next is how they deliver the care, how the nurses deliver the care in the mother newborn care diets in mother newborn care setup. First is support the mother in providing immediate kangaroo mother care. This is a new term, that immediate. What do you mean by immediate? That the kangaroo mother care should be given for at least 8 hours a day per day, and it should be, if we are talking about quantitatively, 80% of more than 80% of the hospitalized days. So mother, in the first picture you can see the mother is walking while the baby is in KMC. Second picture you can see the mother is sleeping with the baby, and third one, mother is getting counseling while the baby is in KMC position. Second point is we assist the mother in KMC garment. In the Safdarjung Hospital we have two garments. First is the binder, that's a triangular shaped binder, cotton cloth, and second is the KMC shirt. So this is how the baby is secured, and I will explain the procedure later on. The third one is the promote and support mother for breast milk feeding. You are surprised to know that while giving KMC we can continue breastfeeding and other feeding techniques also, like expression of breast milk, Pellida feeding, tube feeding, direct breastfeeding, non-nutritive sucking. These all are given while the baby is in KMC position. Fourth one is provide newborn care in KMC position. That in this picture you can see the baby is getting tube feed while the baby is in KMC position. And similarly, we can deliver CPAP, oxygen supplementation, administration of IV injections, monitoring newborn saturation and heart rate monitoring, monitor blood sugar and with glucometer, and we give tube feeding as it is shown in this picture. Next is this is the picture. You can say that mother is also monitored, like saturation monitoring, seeing the baby sleeping in the KMC position, and there is no such disturbance. We should not remove the baby for CPAP delivery and for oxygen saturation monitoring or other glucose monitoring while the baby is in KMC position. Next, what are the key steps involved in kangaroo mother care? First, greet the mother, make the mother comfortable and enable her and explore her what are the questions and give a proper explanation before binding the mother in the KMC position. Second is enable the mother, explain the mother the proper procedures, how the mother is to be, how to mother wear this shirt and binder also, how the baby is to be worn in a napkin and also a cap only. Then place the baby. You know that very well that the baby is to be placed in between the breast and the skin to provide skin to skin contact in a frog-like position, and head is turned to one side, and so that the baby completely rests with the mother's breast. Next, finally, secure and cover the baby. Finally, enable the baby and enable the mother also so that the continuous effective kangaroo mother care is to be done by the mother herself independently. So, if there is any other question asked related to KMC, the mother should be convinced and give proper explanation regarding that. Now, what are the nursing care? This is all I have explained. That what are the this is the essential care package for the maternal as well as for the newborn to provide care in the mother newborn care setup. So now coming to the challenges faced, how they were overcome. First challenge is the transfer, the shifting of the mother from the labor room to the mother newborn care setup. So there must be a policy, administrative support and transportation facility for this. Maintain and sustain NICU environment. So we should maintain asepsis and strict visitor policy for that. Convince the mother to keep sick neonates in KMC position. So for this we need to explain effectively and involve family members also to provide continuous KMC. Maintain CPAP interface in KMC position. For this effective training of the nurses should be done in mother newborn care setup, and all the procedures like blood sugar monitoring, oxygen saturation monitoring, feeding, and all like nurse acts as a liaison in between obstetrician as well as for the pediatrician for any SOS call. So these all are the challenges, and they can be overcome with effective interventions. So other problems must be there, like mothers can say kangaroo mother care is tiring for them, and there must be, they can be resistant by the mothers. Cultural barriers are also there. Sleeping with the KMC, so many mothers ask this question, and there are so many myths about suffocating the newborn. So you should explain the mother that there are the evidence-based researches which reveal that the apnea, the risk of apnea is reduced when the baby is in KMC. And after giving appropriate explanation and enhancing knowledge regarding the kangaroo mother care, along with the empowerment, community empowerment and family-centered care, we can provide immediate and effective kangaroo mother care to the both newborn and the mother. Now coming to how the nurses perceive the delivery of the care. So we know that the nurses, those who are working in a mother newborn care setup, there is a much task shifting. Like this is more explained in this picture. Here is the mother which is changing the diaper. So much of the work of the nurses are shared by the mother. And in the second picture, mother is also providing breastfeeding. Mother can give pellida feeding. So many work that somehow, to some of the extent, mother also do monitoring of the newborn. This is all done by mother. So we can enable the mother by explaining all these things to the mother and the newborn. In the last picture, you can see the baby, mother is giving KMC to the twin babies. So this actually increases the confidence level of the mother. Next is, the mother newborn care setup provides the opportunity for better preparedness of baby as well as to the mother. So we can give effective counseling. So last is the nurse's perception must be like this. There must be improved breastfeeding rates, reduce the risk of infections, and the baby maintains stable temperature and heart rate stabilizes after the baby rise up for effective KMC, and the mother also sleeps better when providing KMC in a mother newborn care setups. So I'm ending with this quote: the mother newborn care unit provides a platform to deliver holistic, respectful care to both mothers and newborns, while maintaining nature's norm of zero separation preparation and thus promoting early childhood development. Thank you all.
Thank you, everyone.
There are so many myths and cultural barriers regarding this. That most of the mothers they say it's a simple practice. How it will lead very good effects. Like we should explain all the benefits of kangaroo mother care. I have witnessed one of the case where the mother is resistant. That my baby is too the birth weight of the baby is too low, around 1 kg of the weight. The mother was so anxious and mother is not able to do kangaroo mother care. So after giving proper explanation, we for tiring of the mothers, we take help from the surrogates also. We explain it to the father and the family that by providing effective KMC. So I have witnessed that the baby got discharged at the birth weight of 1.8 and right now the baby is 6 months of age and he is doing well. So, not only just for the sake of mortality and mobility, there is a long-term effect. Neurodevelopmental growth of the baby also enhances because of kangaroo mother care. So, by giving proper explanation, enabling the mother to do the kangaroo mother care independently, and according to the latest rule from the WHO, it is said that below the 2.5 kg of the weight, all the babies should be started kangaroo mother care immediately soon after the birth. So at home, KMC should be continued. So this proper explanation before the discharge enable the mother and the family to do effective KMC. And that's how we save so many lives and also enable the mother to do continuous KMC along with provide exclusive breastfeeding. Thank you.
Thank you. So now the session is open for the audience. If you have any query, you can ask. You can ask directly to our panelists. You can mention the name also.
Myself, Dipali Sarkar. I'm working in Apollo Excellent Care as in charge in NICU and PICU. So my question goes to Ma'am Bhavna Verma ma'am. As you have mentioned the challenges we face during giving KMC, like mothers used to say they are tired, they cannot hold the baby for long. So in that case, what shall we, how can we approach mother or tell her that it is very important?
KMC can be continued with the grandmother, father also, and any member in the family, so that the mother can take nap in between. Because for exclusive breastfeeding, mother oxytocin, you know about the oxytocin reflex, they need to be relaxed, they need to be calm and got proper sleep. So by helping taken from the surrogates, that is grandmother or grandfather or father, they can continue give KMC in between when the mother got tired.
Thank you, ma'am.
You see, mother can be 21st KMC, it is no problem, apart from only feeding, because mother can sleep. Baby will be monitored by nurses when babies needed some support. At home, baby they can be helped by grandmother or mother, because at NICU within it is not possible. It is not that mother has to alert and monitor. Monitor will be there, nurses will be there. Mother can sleep and mother can take peace in the same way. Even both in the same way, both mother and baby can get treatment. No problem.
Thank you.
And one more question. You have mentioned mother and newborn you live together. So is there any risk of getting infection for the baby from the mother if they live together, both of them?
Yes. There is a study also, which is a WHO trial study, and it has been proved that the risk of infection in the newborn, because the microbes which are there in the mother, they are transferred to the baby, and it is been seen that the risk of infection actually reduces when the mother stays with the newborn. What you can do, you should explain how the strict visitor policy must be there. Second, explain all the personal hygiene as well as proper hand washing technique to the mother, and ensure that the mother, there is no such question regarding if the mother is having fever, the same will be transmitted. The baby will get more benefited after KMC when the baby is attached to the mother. So eventually the risk of infection reduces. There are so many studies. I can give you the link also for that study.
You see, mother's skin is very friendly bacteria. Baby's skin must be colonized with the mother's bacteria. The number of cesarean section increasing, babies not get infection for the mother's normal vaginal flora, so many allergic diseases are increasing. So mother's normal skin and vaginal flora bacteria won't harm the baby, number one. Number two, as I say, he is saying, of course, hand washing very important. Mother's hand may give the baby this, but mother also will give the protection. Before doing KMC, of course, mother has to do few precautions like taking bath, wearing clean clothes. But still, mother is the best, much safer than an incubator or a bed. What we were doing when the mother was having coffee? Did you keep the baby away from the mother? No. We just ask mother to wear a mask, give breastfeeding. Because if baby is not breastfeeding, baby's chance of getting infection will be much higher than mother is having. Then mother is giving breastfeeding with proper precautions. The mother is the best protector, so chance of getting infection from the mother it's much less than if baby stay away from the mother. Even mother is having HIV, mother is having hepatitis B, we never keep the baby away from the mother and try to breastfeed. Okay?
Sir, actually, I need to mention about the sick babies, not the normal babies who are in oxygen support and CPAP support.
Yeah. She has already shown in the pictures. If you have noticed, if baby is in CAPF, NIV, otherwise stable can. If the baby is having intracranial hemorrhage, baby is very situation is fluctuating, not maintaining, then only very unstable baby with heart failure, hemorrhage, bleeding, baby dying, heart rate is not stable, then only. Otherwise, baby is just needing NIV, non-invasive ventilation, CPAP, oxygen, and the feeding, all feeding, baby can give, should get KMC. She has already shown the pictures, if you have noticed it.
Yes, thank you so much.
So here we came to know why the safe childbirth is very important for us. Recognitions of your recognizing of your postpartum complications and all, and why this KMC it is very important for the babies. So I would like to thank our panelists for sharing your valuable contributions. I would also like to thank all the audience for your attentive participations and thoughtful questions. So today, your participations has enriched these sessions and made it more meaningful. Thank you all.
Thank you to our distinguished chairperson and all the respected panelists for such a rich and enlightening discussion. I now take a moment to honor our distinguished chairperson and panelists for their valuable contribution. I kindly request Madam Ms. Anurupa Datta, Madam Ms. Sujana Yambam and Madam Ms. Vanita Burman to kindly come and do the honors.